We all know that managing tibial plafond injuries are difficult, mainly because there are no standard fracture patterns. The combination is invariably severe. There is an associated soft tissue damage, and there is a high risk of post-traumatic arthritis. The mechanism of injury depends upon the position of the foot at the time of injury. And these three modes of failure have already been discussed by my co-convener: the axial failure, the varus angulation, and the valgus angulation. Also, the Rudy Algov's classification was given way back about 4 decades ago. And then we also have a AO classification. The C2 and the C3 injuries are basically the injuries which I will be dealing in this talk, and they are described as the complex injuries. Whenever we see these injuries, the standard imaging protocol that we do are the X-rays and the CT scan. The advantages of getting a CT scan is better orientation of the fracture, better understanding about the articular involvement, and one can plan the surgery better. If one is planning for a two-stage fixation, probably one can go with doing a CT scan twice. However, if one wants to do a CT scan just once, then it's better to do it before the final stage. These are the principles laid down by AO for the fixation of tibial plafond. The first is anatomical reduction of the articular fragment. The second principle is stable internal fixation. The third principle was added later on, which is atraumatic surgical technique. And finally, rehabilitation has to start earlier. So what are the factors which decides on when to go for a single stage and when to go in for a two stage? So basically, if it's a low energy injury, lesser degree of comminution, it's away from the joint, one can go in for a single stage. However, it's a greater degree of comminution, probably one may think of going in for a two stage. The second point to be considered is it a closed injury or an open injury? Open injuries are best managed with two stage. The third point one need to consider is the time of presentation. If the patient has presented to you earlier, probably one can go in for a definitive fixation in a single stage, but if the patient has presented late, it's wiser to opt for two-stage fixation. Thus, the decision essentially depends upon the clinical as well as the radiological assessment. In the clinical assessment, we essentially look for the skin condition in the form of whether it's open or closed, or are there associated blebs. The sensory and the motor functions of the foot also needs to be evaluated, and one needs to keep the compartment syndrome in the rare cases in mind. The degree of comminution, higher the degree, probably that can again help you. Thus, early definitive fixation is preferred if the patient presents within 72 hours and has a closed type of injury. However, if the patient presents late or has an open injury or has a severe swelling or have associated blisters, then probably one can plan a two-stage. In the first stage, a surgeon can take a help either of the splint or put a simple calcaneal pin and give a skeletal traction, or even put in an external fixator. One needs to wait for a period of about 10 to 14 days, let the inflammation settle, look for the wrinkle signs, and then go in for a definitive fixation. So what are the types of fixation? One stage fixation can be purely only internal fixation, or a modification which is a MIPO or a MIS technique, or at time one may combine both ORIF with a X-fix. Whereas a two-stage fixation, a stage management protocol would consist of one of these three methods. In the first stage, you put a X-fix and then convert it into a internal fixation, or in the first stage, you simply put in a calcaneal pin, wait for some time, and then go in for a definitive fixation, or do a closed reduction, put in a splint, let the skin condition improve, let the inflammation settle down, and then go in for a definitive fixation. When it comes to a definitive fixation, the role of anatomical reduction cannot be overemphasized. That is one factor which definitely predicts the outcome. The role of fibula fixation has already been talked about. When one tends to fix the fibula first, one achieves the length and thereby corrects the coronal and the transitional alignment. If the syndesmosis is intact, it also helps in reducing the articular fragment. The approach of choice for fixing the fibula fracture remains posterolateral approach. Now, the external fixator used in a two-stage management can either be an ankle spanning external fixator or a hybrid fixator. The principle of an ankle spanning external fixator is it works on the principle of ligamentotaxis, and thereby it helps in realigning the fragments. What is important is one should try to keep the surgical area which will be used for the definitive fixation virgin, so that in case of pin tract infection, the second surgery won't be delayed or get complicated. What are the tips to put this external fixator? It is best put within 24 hours of presentation or injury. First, do a fibula fixation, then put 2 pins in the tibia, 1 pin through the calcaneum and 1 pin on the medial aspect in the midfoot in the cuneiform. This will prevent the equinal deformity. Now, once you have put in an external fixator, it is important to assess the alignment of the ankle joint. One should try to draw a line from the center of the talar body, and it should pass through the intact tibial shaft, which is the proximal fragment. In this case, you can see that they are not coinciding, so this is not a well applied external fixator. Is there any role for an external fixator even in a one stage? Yes. In cases of very severe degree comminution, or if there is a severe impaction with a small osteochondral fragment, probably one can put an ankle spanning fixator. One can slightly over distract the joint, keep in place for 4 to 6 weeks and then remove. One has the option of doing a primary or a secondary bone grafting. What if there is a metaphyseal defect? The size of the defect will decide how to manage it. Less than 5 centimeter of defect, one can go in for a autologous bone graft or a structural fibula graft or use any bone graft substitutes. However, if it's a large defect, one can go in for a Masculus technique or use a distraction osteogenesis or a vascular graft. At times, if your decision is not right, this is what happens here. Probably a medial plate would have been a better option and would have covered the medial column. Thus, if one assesses the pros and the cons of one stage, the advantages of doing a definitive fixations are it helps in earlier mobilization, there are decreased chances of joint stiffness, the hospital stay goes down, and so does the cost. What are the disadvantages? At times one may land up with a post-op infection, wound closure is difficult, and at times one may have difficulties in getting a wound healed. Whereas the advantages of one stage procedure are disadvantage of a two-stage procedure. The two-stage procedure will invariably lead to an increased duration of stay, increased cost, and high chances of joint stiffness. My co-convener, Dr. Shetty sir, he has already described the various approaches, so I won't go into the details. He has also mentioned about the 3-column concept. Basically, what decides your approach? It is essentially the location of the articular fragment and the balancing the biomechanics. That's what going to dictate your approach. The MIPO approach is best used in an extra-articular injury or a periarticular injury. Then we have these various approaches which have already been described. So essentially the complications of a tibial plafond injuries are, one may have a wound dehiscence, infection, a varus malunion, a non-union, or even a post-traumatic arthritis, and at times stiffness. When we reviewed the literature about one stage versus two stage, this is a paper which concluded that the present evidence has shown that two-stage procedure is associated with lower risk of post-operative complications like superficial infection, non-union, and bone healing. However, both the methods, one stage as well as two stage, the incidence of deep infection, arthritis, and chronic osteomyelitis remains the same. So what's the take-home message? One stage fixation should be preferred in a low energy injury where there is a good skin condition and patients who presents early. Whereas a stage fixation should be reserved for a high energy injury, poor skin condition, patients who present late, or as a part of a damage control orthopedics in polytrauma, or where there is an associated neurovascular injury. Thank you.